Hi there, my name is Dr. Denis, and together with Dr. Kai, we're broadcasting today from Winter Berlin and Winter Toronto, and we would like to discuss with you a case from the ASAS Case Library, case number 45. In this case, as you see, we have a 57-year-old woman who presents with chronic back pain that started slowly about 9 months ago. The pain is predominantly located in the lower back with some radiation into left buttock. Overall, she describes quite typical inflammatory characteristics, including prolonged morning stiffness, some improvement of pain with exercise, and worsening with rest. She also wakes up quite frequently in the night because of back pain, and she already tried some non-steroidal anti-inflammatory drugs over the counter that provided with a little bit of relief. She has no other typical spondyloarthritis manifestations, also no history of known extramusculoskeletal manifestations, no signs, symptoms suggestive of peripheral disease, no family history. There are also no major mechanical stress factors. So she works as a teacher and she stays professionally active. Her obstetric history included 2 pregnancies with deliveries at age of 35 and 37 without major back pain during the pregnancy and after this pregnancy. She has as comorbidities postmenopausal osteoporosis, which is currently being treated with calcium and vitamin D supplementation, and she's not doing a lot of sports or other physical activities. So all in all, clinical presentation not immediately suggestive of inflammatory disease, but there is an inflammatory back pain in a lady that is bothering her. When we investigated this lady, we found that she's in general in a good condition with a body mass index of slightly above 26. On examination, there was some reduction of lumbar spine mobility, potentially related to pain, no peripheral arthritis, no psoriasis, and there were no major findings on neurological examination. We did also some lab work, and in the lab, we found that CRP is only slightly elevated, and HLA-B27 was tested as positive, no abnormalities otherwise. She brought also to us images performed in the community. So the primary care doctor, in this case orthopedist, performed MRI of sacroiliac joints and spine. And although the protocol of this MRI examination doesn't correspond to the state-of-the-art protocol we recommend nowadays, still we see in the left sacroiliac joint this massive bone marrow edema. At the same time, you may realize there is a bit of scoliosis in the lumbar spine. So the question is, what is actually going on with this massive bone marrow edema? It's reasonable to think about potential infection or other not immune related condition. And because of this mechanical issue in the lumbar spine, we can think about potential mechanically induced bone marrow edema. So, Kai, what do you think about this pattern, and how to differentiate in this case between potential differential diagnosis?
Yes, thank you, Dennis. Indeed, this is an interesting pattern. We have this very intense bone marrow edema that's adjacent to the left sacroiliac joint. We see the bone marrow edema is in the ilium, but also in the sacrum. And if we go through the slices, we might also see that the cortical line is disrupted over here, which gives the suspicion of an erosion. And in fact, this really looks very much like an erosion. We also have a little bit of signal of high signal intensity within the joint space. But also what we need to consider is the distribution of the edema and also the findings that we can see on this particular MRI series as well. So we see some scoliosis. So if you see the scoliosis, there's a significant scoliosis in this patient. Scoliosis is always a reason to think about mechanical reasons for any changes in the sacroiliac joints. Usually it's creating increased forces on the load zones, which are predominantly in the anterior slices located. And what we can see as well is some slight soft tissue reaction close to the sacral bone. If you compare to the other side, it is not there. And here, if we go to the anterior capsule, there's also some slight reaction that is not here on the right side. And the distribution of the edema inside the joint needs to be considered. Usually we try to start to approach the joint from the anterior slices. So this is our slice 2. This is maybe the first slice that shows us the joint space. There's some edema already here to be seen. Edema is in its largest representation in slices 5 and 6, which is still the anterior position. But then if we go into the posterior aspect, so here we see then the nerve roots of the sacrum here in this area, the nerve roots of the sacral plexus, and we still see the edema, and this continues until the very posterior aspect in the sacrum. So we could not establish a purely anterior pattern here, as you would have expected it in osteitis condensans. Also, looking at this sequence, we see there is some edema also here in the upper part of the lumbar spine in the vertebral bodies. So this is an orthopedic protocol. So we of course have now a T1 weighted scan, and also we have a T2 weighted scan. And if we look here, so we don't have a stir sequence, because stir we already have in the coronal plane. So we need to do our analysis with the T1 and T2. So if we go to the central slice, which is here slice number 8, and here in this example, it's maybe slice number 7. So these two sequences, they are not, they don't have the same slice number. You see, these are 16 slices, these are 15. So this explains why here the central slice is slice 7, and here the central slice is slide 8. So you always need to adapt a little bit. And what you can see here, maybe here, that's a better representation of the cauda equina here in this regard. So what you can see here is multi-level bulging of the annulus fibrosus. You see that the fluid component that you would expect in the nucleus pulposus is no longer there. We have dark discs throughout the lumbar spine, except these two upper segments over here. So this shows us there is some significant amount of degeneration. Also, we see the height of the vertebral intervertebral disc is reduced in the L4, L5 area. We can see it again here in the T1. Much better, so to say. Also here we have a decreased disc height. So there's a lot of degeneration going on in the lumbar spine. So this would also reinforce our thinking of mechanical induced edema pattern. Then if we look at the axial scan, we can see that there is the edema showing up as dark signal intensity. But this particular sequence gives us the option to look in more detail into the joint space itself, because now it's a T1 weighted scan. We see the fluid is dark, so this is a T1 weighted scan. And as we remember, on T1 weighted scans, we can search for structural damage like erosion, backfill, ankylosis, and other of these lesions. So taking a closer look, we can see that the joint space has an irregular contour. This is the cartilage in the joint. we might see irregularities also here, where we did see some erosions in the stir sequence already. Maybe this is the large erosion that you could see. And on the right side, which did not show any inflammatory active lesions, we see there are more erosive defects. And here in this anterior area, I'm not sure whether there are already erosions with repair phenomenon, so-called backfill sign. So this is quite an interesting picture of destruction and structural damage of the sacroiliac joints in combination with edema that we see in most regions of the joint, in most parts of the joint. There is some focus of the anterior slices, that's true, but the inflammation goes until the very posterior aspect. So I would think this is a case where also some inflammation in terms of axial spondyloarthritis plays a role. So that is the approach to imaging, how I would see it.
Yeah, very good. And I think it's a very interesting case, although we're saying this is late onset of axial spondyloarthritis. Structural changes in the sacroiliac joint, which is currently not affected by inflammation, they told us that probably the disease exists already for many years. It is a question, of course, why this inflammatory condition became clinically relevant only now. She had structural changes in the right sacroiliac joint indicative of previous inflammation, which obviously went for quite some time without major clinical manifestations. But it happens, especially in H-between-27 positive subjects. An infection or another event may trigger massive inflammatory flare, and this is likely what's happened also in this case. The disease was for quite some time pretty calm and not clinically manifest, but in the last several months, because of this increased inflammatory activity, it became clinically relevant, and this is when we captured it. And as you explained very nicely, the pattern, there are definitely mechanical degenerative changes, but the pattern of bone marrow edema, especially in combination with structural damage on the other side, says that it's likely an inflammatory problem, and we do not have major concerns about infection or malignancy. Would you agree with this?
Yeah, I think this is a very good explanation and interpretation. So based on your experience, how would you grade, if you grade the likelihood or your own diagnostic confidence between 0 and 5, what would you give here for this case?
Yeah, I believe this is very close to 5. I'm pretty convinced in the whole story, and also the appearance, the pattern of changes in the sacroiliac joints looks very much compatible with inflammatory immune-mediated condition we call AXSpA. In your eyes, what would be the diagnostic confidence that this is?
So I would give it a 3 or a 4, because as I said, the scoliosis is a big distractor, and the distribution of the edema is also kind of suspicion. But of course, on the other hand, we have erosion, which increases the likelihood for axial spondyloarthritis dramatically. So maybe I end with a 4. And also as we know, the age is unusual, but she's the BMI is not, she's not in an extreme obesity, so it's only the scoliosis that's one factor for mechanical overload of the sacroiliac joints. And of course, the 2 pregnancies might also have played a role, but as you laid out, they were unremarkable. So this is quite a case from the daily clinic. Very interesting.
Very good. Very good. Yeah, thank you very much, Kai, for the explanations of the imaging and the explanations also of the particular protocol which has been performed here. I think that this protocol is still pretty common, especially if you see patients coming to you from orthopedic clinics. Very often the protocols like this are performed, and then we need to decide whether or not we need additional proper imaging for sacroiliac joints and for the spine. But I think in this particular case, we received enough information from what was available.
Exactly. A wipe sequence would certainly be beneficial, but of course, it takes a long time until the ASAS endorsed protocol takes over in most radiology institutes. So here you see also our ASAS Online Case Library again with the many cases that we collected so far. So it's always worthwhile checking by. Cases starting with number 20 all have a video review, so it's a good resource to learn.
Very good. Thank you very much for listening and watching. Please scroll through the images by yourself, and we'll see you soon.
Bye-bye. See you soon.